Hello, my friends, my family, and my fans. I'm Andrew Ditch. I've been diagnosed with autism and intellectual disability. Today, I want to talk about a really important topic. This is very important for millions of other adults with autism. This topic shows how incompetent the medical and mental health field really is. You go to a doctor when something bothers you, like when physical pain, stomach problems, or even when your behaviors are not seen as the social norm. This is where I start with how incompetent doctors are in identifying autism and intellectual disability, and how they often can use masking as a way to misrepresent someone's behaviors as noncompliance or argumentative rather than part of their intellectual disability or developmental disability. Stigma, bias, and ableism. Autism stigma. Autistic traits are still framed as behavior problems, noncompliance, or poor attitude, especially for people of color, non-speaking people, and those with intellectual disabilities. Mental health stigma, fear of being labeled dangerous, unstable, or unfit for work, parenting, or housing, discourages people from seeking help. Intersectional bias, race, gender, class, and disability intersect. Black, Latino, and indigenous autistic people are more likely to be criminalized or ignored rather than supported. Below is a deeper, clearer, and more connected explanation of stigma, bias, and ableism in autism and mental health care, especially how these forces shape diagnostic outcomes, access to services, and safety. I'm expanding each point so you can use this for education, advocacy, or content creation. New Moon stigma, bias, and ableism in autism and mental health. These forces don't operate separately. They stack on top of each other. When someone is autistic and part of another marginalized group, the effects multiply. 1. Autism stigma. Traits are misread as behavior problems. Autistic communication and sensory responses are still widely misunderstood. Instead of being recognized as neurological, they're framed as attitude, defiance, or poor behavior. Common misinterpretations. Shutdowns, ignoring instructions, meltdowns, tantrums or aggression, sensory overload, overreacting, difficulty with transitions, noncompliance, monotone speech, rudeness, stemming, disruptive behavior, literal communication, attitude, or smart mouthing. Who is most affected? People of color, non-speaking, autistic people with intellectual disabilities, autistic adults who mask well until they can't. These groups are more likely to be punished, labeled difficult, denied accommodations, excluded from services, subjected to restrictive or behavioral interventions. This stigma is rooted in ableism, the assumption that neurotypical behavior is the correct or normal way to exist. 2. Mental health stigma, fear of being seen as dangerous or unfit. Autistic adults often avoid seeking mental health care because they fear how they'll be judged. Common fears: being labeled unstable, being seen as dangerous during meltdowns, being considered unfit for work, being considered unfit for parenting, being placed under unnecessary supervision or guardianship, being hospitalized or restrained, being misunderstood by crisis responders. These fears are not irrational. They're based on real patterns in the system. Why autistic people hesitate to seek help. Crisis teams often misinterpret autistic distress. Hospitals may use restraint instead of sensory support. Providers may assume autistic adults lack insight. People worry about losing autonomy or rights. Stigma creates a chilling effect. People avoid care until they are in crisis, and then the crisis is misinterpreted. 3. Intersectional bias, when race, gender, class, and disability intersect. Autistic people who are also part of marginalized racial or gender groups face additional layers of bias. For Black, Latino, and indigenous autistic people, distress behaviors are more likely to be seen as aggression. Meltdowns are more likely to be treated as threats. Shutdowns are more likely to be seen as defiance. They are more likely to be criminalized instead of supported. They are less likely to receive early diagnosis. They are more likely to be misdiagnosed with behavior disorders. They are less likely to be believed when reporting pain or trauma. For autistic women and non-binary people, Autism is often missed or misdiagnosed. Masking is interpreted as doing fine. Emotional distress is labeled as personality disorder traits. Trauma is overlooked or minimized. For autistic people in poverty, fewer providers, fewer autism-competent clinicians, more reliance on crisis systems, more exposure to punitive or restrictive environments. For autistic people with intellectual disabilities, their emotional experiences are often dismissed. Pain is frequently ignored or misinterpreted. They are more likely to be placed in restrictive settings. They are less likely to receive trauma-informed care. Intersectional bias means that the more marginalized identities a person holds, the more likely they are to be misunderstood, punished, or ignored. 4. How these biases shape real-world outcomes. A. Misdiagnosis and misdiagnosis. Depression, flat affect, anxiety, rigidity, PTSD, behavior problems, suicidality, attention-seeking or not serious pain, sensory sensitivity. B. Punitive responses instead of support. Behavior charts, compliance goals, restraint, or seclusion, police involvement during crisis, removal from programs. C. Reduced access to services. Being labeled too high functioning for support, being labeled too impaired for mental health therapy, being bounced between autism, mental health, and ID systems. D. Loss of autonomy. Guardianship threats, over-supervision, being treated as incapable of decision-making. E. Increased crisis risk. Avoiding care due to stigma, burnout from masking, trauma from past negative experiences, lack of autism-competent providers. 5. The core insight. Autistic distress is often misread because the system is built around neurotypical assumptions. Autistic communication is misread as attitude. Autistic distress is misread as behavior. Autistic trauma is misread as defiance. Autistic calmness is misread as stability. Autistic articulation is misread as capability. Autistic shutdowns are misread as refusal. Autistic meltdowns are misread as aggression. And when race, gender, class, or disability intersect, these misinterpretations become even more dangerous. This is why autism-specific expertise is not optional. It is essential for safe, equitable, and humane care. Waivers and programs. PA has multiple Medicaid waivers and an Office of Developmental Programs, ODP, but eligibility criteria and administrative hurdles can exclude autistic adults who are seen as too independent or not disabled enough, even when they cannot safely manage housing, health, or daily living. Urban areas, e.g., Pittsburgh, Philadelphia, have more autism specialty clinics and academic centers, but wait lists are long and often child-focused. Rural and small city regions, like much of northwestern PA, have severe provider shortages. Autism-informed adult mental health care is extremely limited. Downstate concentration. New York City and surrounding counties have more autism and mental health specialists, including hospital-based programs and university clinics, but they are often overwhelmed, selective, or inaccessible to people on Medicaid or with limited transportation. Upstate gaps. Many upstate counties have very few autism-competent adult clinicians. People may travel hours for care or rely on telehealth, which not all insurers or programs support equally. OPWDD and mental health split. New York's developmental disability system, OPWDD, and mental health system are often siloed, making it hard for autistic adults with co-occurring mental health conditions to get integrated support. Below is a polished, expanded, and tightly connected explanation of the regional systemic barriers in Pennsylvania and New York, focusing on waivers, program design, geography, and the autism, mental health divide. I've organized it so you can use it directly in educational materials, advocacy writing, or YouTube content. Compass regional systemic barriers in Pennsylvania and New York. Autistic adults in both states face structural gaps that have nothing to do with personal ability and everything to do with how services are designed, funded, and distributed. These gaps are especially severe for adults who need autism-competent mental health care. United States, Pennsylvania, waivers, geography, and system fragmentation. 1. Waivers and ODP. Eligibility barriers and administrative hurdles. Pennsylvania has several Medicaid waivers and the Office of Developmental Programs, ODP, but the system is built around narrow eligibility definitions and bureaucratic gatekeeping. How autistic adults get excluded. If they speak fluently or advocate for themselves, they may be labeled too independent. If they don't have an intellectual disability, they may be labeled not disabled enough. If they mask well during assessments, evaluators may underestimate support needs. If they struggle with executive functioning, sensory overload, or daily living, but can articulate their needs, they may be denied because they appear capable. Real-world impact. Autistic adults who cannot safely manage housing, health, or daily living are denied services that would prevent crisis. People fall into a gap between mental health, autism, and intellectual disability systems, none of which fully claim responsibility. 2. Urban versus rural divide in Pennsylvania. Urban areas, Pittsburgh, Philadelphia. More autism specialty clinics, more academic medical centers, more diagnostic resources, more therapists with at least some autism experience. But wait lists are extremely long. Most programs are child-focused, not adult-focused. Adult autism mental health programs are rare. Medicaid acceptance is inconsistent. Rural and small city regions, e.g., northwestern PA, including Erie region. Severe provider shortages, very few autism-competent adult clinicians, limited psychiatry availability, long travel distances for specialty care. Telehealth may not be covered or may be limited by broadband access. Result: autistic adults in rural PA often face no realistic access to autism-informed mental health care. Statue of Liberty, New York. Concentration downstate, gaps upstate, and system silos. 1. Downstate concentration, NYC, Long Island, Westchester. Downstate New York has more autism specialists, more hospital-based programs, more university clinics, more mental health providers overall. But programs are overwhelmed and selective. Many do not accept Medicaid. Wait lists can be months to years. Transportation barriers make access difficult for low-income autistic adults. Result: even where services exist, they are often inaccessible. 2. Upstate gaps. Upstate New York counties, e.g., the Southern Tier, North Country, Western New York outside Buffalo face very few autism-competent adult clinicians, limited psychiatry availability, long travel distances, 1 to 3 hours each way. Heavy reliance on telehealth, not always covered by insurers or waiver programs. Result: autistic adults may have to choose between no care and care that doesn't fit. A forced compromise that worsens burnout and crisis risk. 3. OPWDD and mental health system split. New York's developmental disability system, OPWDD, and its mental health system operate in separate silos. What this means in practice: OPWDD may say, this is a mental health issue. Mental health programs may say, this is an autism issue. Neither system provides integrated care. Autistic adults with co-occurring mental health conditions are bounced between agencies. Crisis services often lack autism training, leading to misinterpretation and trauma. Result: autistic adults with mental health needs fall through the cracks, not because their needs are unclear, but because the systems refuse to coordinate. Magnifying glass, tilted left, cross-state patterns. What Pennsylvania and New York have in common. 1. Child-focused infrastructure. Both states have far more autism services for children than adults. 2. Adult mental health programs lack autism expertise. Clinicians are not trained in autistic communication, sensory needs, shutdowns and meltdowns, autistic trauma, AAC, intellectual disability, plus autism profiles. 3. Waiver systems exclude people who mask or appear too capable. Verbal autistic adults are routinely denied services despite significant support needs. 4. Geographic inequity. Urban centers have more resources but long waits. Rural regions have almost none. 5. System silos. Autism, mental health, and intellectual disability systems do not coordinate, leaving autistic adults unsupported. Puzzle piece: the core insight. Autistic adults in both Pennsylvania and New York face structural barriers, not personal shortcomings. The system is designed in a way that rewards, masking, punishes, distress, misinterprets autistic communication, excludes people who don't fit stereotypes, prioritizes children over adults, prioritizes urban centers over rural regions, prioritizes behavior management over trauma-informed care, prioritizes bureaucratic eligibility over real-world functioning. These barriers are predictable, preventable, and deeply harmful. If you want, I can help you turn this into a YouTube script, a slide deck, a visual comparison chart, PA versus New York, a policy brief, a narrative example illustrating these barriers. Just tell me the format you'd like. If you're interested in disability topics, such as treatment, support, accommodations, and rights, like this video and subscribe for more inclusive content. I will talk to you on my next video.